Humans' health and well-being is key to a prosperous future. But the landscape is changing. Individuals are taking health back into their own hands, urging for transparency, more options, and less red tape. NEOM is creating a new, holistic health and well-being ecosystem that caters to all world citizens, where people, not hospitals, are at the center of the system and can live, thrive, and be heard. Supported by the latest medical advances with a focus on proactive prevention, not just treatment. The knowledge is there, and the precedent has been set. Sweden is a leader in the telehealth space and uses a collaborative, patient-centric approach. South Korea offers high-quality universal healthcare backed by extensive research. And Singapore and Japan are home to those who live longest in the world. But it's all happening in isolation. Imagine what we can do together. NEOM will tackle some of the world's toughest health problems, pioneering a new standard of well-being, with a focus on pain management, muscular and skeletal diseases, and cancer, and a balanced approach to overall well-being, mind, body, and soul. Co-created with and personalized for the NEOM community, encompassing integrative care and complementary medicine, and at the forefront of research, telehealth, and digital solutions. NEOM is committed to livability, longevity, and quality of life. The future of health and well-being starts at NEOM.
Our next panel is obviously one that plays right off of the panel session and the keynote that Alan had basically talked about. It's the COVID-19 healthcare impact, redesigning the use of data in healthcare. We are unfortunate in that Dr. Malia Hashmi was called away at the last moment, but we are fortunate in that we still have Elizabeth Robilotti. She is the infectious disease specialist at Memorial Sloan Kettering Cancer Center. And I'm going to turn it over to Elizabeth and to Dr. Ghassan Abu Alfa to basically present and discuss this panel. And we will also open it up to questions because, again, I think on the heels of Alan's very timely comments and plan, we will be able to address some interactive questions from the audience. So with that, I'll turn it over to Dr. Ghassan and to Dr. Robilotti.
Good morning, everyone. Thank you so much for having me, and I am certainly missing Dr. Hashmi this morning. I enjoyed very much speaking with her on our last panel. I wanted to pick up on a couple of things that that were mentioned in the keynote, particularly the idea that COVID-19 is the story of data. I don't think you could have said anything more apropos, except with what you followed that with, which is that it has to be dynamic and scalable. And that's, I think, what we've all been living for the last year. And to that, I would add that I hope we'll be able to show you that data is actually the hope for how we get out of the situation that we have all found ourselves in. And I only started thinking about this recently as I was doing a review of the experience of cancer patients and COVID-19. And I looked at that literature my original training is actually as a historian. And so I kind of periodized it. And it has just been a massive evolution in a short amount of time. We started in the beginning with just being able to even sequence the virus. And that was in January. This is a completely unknown virus before before January. And in a matter of weeks, it was sequenced and posted online, and people could start designing targets and interventions to help mitigate its impact. And now here we are, basically 11 months later, and we're already talking about potential viable vaccine candidates. And this is really a monumental accomplishment in terms of data analysis, data production, and data integration. Because if you put this in perspective of other pandemics that we've faced, we've known about flu for hundreds of years, and we still have periods of trouble with that. Polio, it was 60 years between identification and then ultimate distribution of a vaccine. Ebola, it's about 15 years between outbreaks and vaccine, and the other coronaviruses that have plagued us, SARS-CoV-1, or original SARS, as some people call it, and then the MERS-CoV. There's still no vaccine candidate for either of those agents. So this experience that we've all gone through really is the story of the triumph of big data, I think. And I will remain optimistic, although completely humbled by the sheer human scale of the disaster, and recognizing the number of lives we have lost. But on that note, I wanted to talk about a couple of ways that we actually transform patient care data to inform what we did at Sloan Kettering. And I know that this was a parallel path that a lot of places undertook. And one of the great advantages that we had is we had a really robust healthcare information system and a track record of mining that system for clinical data to look at outcomes. And this proved invaluable in the first phases of the pandemic, which, as you all know, it hit New York City in the beginning of March, and then quickly took off, making New York the global epicenter for several months, March, April, May. And in that time, we were able to identify from our healthcare records key pieces of data that would tell us which patients may be at risk for more severe outcomes from the disease. And we did this in a variety of ways. One was initial identification of symptoms that could be predictive of severe outcome. But probably the most valuable was when we actually were able to analyze patients who'd received chemotherapy and surgery, and to be able to tell which patients could be at risk. So, there was a palpable fear. Thousands of patients had received chemotherapy in January and February, or had undergone major surgical procedures related to their cancer. And then the pandemic hit, and it was sort of unknown at that time what that would mean for those patients. And, the horse was out of the barn because they'd already received their treatment. And reports coming from China and Italy were actually quite disturbing, that the real burden of mortality was among patients with comorbidities, including cancer, and that some of those rates were 5 times the mortality of the general population. So we were able to comb our electronic healthcare record and actually pull out these details. And fortunately, what we were able to identify was that patients who had received chemotherapy within the last 30 days or had undergone a major surgical procedure were actually not at increased risk for severe outcomes from COVID. And this one gave everyone a sigh of relief, but also some confidence to go forward, because while COVID preoccupied, many of us, cancer did not stop just because COVID also hit. So I'm wondering if anybody in the audience has any questions about that, or if not, we can go on to talking about data visualization and how we have used that pretty successfully.
Elizabeth, I have a question, if I may.
Sure.
With the news and the announcement yesterday that it looks there's a vaccine coming down the road from, is it something that you think is really inevitable, or is it really, to your point, where polio has still taken time as the flu has still had a vaccine that hasn't mitigated it 100%? Do you think this is something that is really within reach?
Yeah, it's a great question, because there's a lot of hope hanging on this. And what's amazing about the vaccine initiative is that there are several different platforms that are being evaluated. The two most aggressively funded and pursued are based on a completely novel technology called messenger RNA. And they're the two products that are the furthest along in terms of clinical trials. I think that the first one we get in terms of vaccines is not going to be the end of the story on COVID-19 vaccine, but it will likely provide some benefit, even if that benefit is transient. It can at least get us started back to kind of a more normalized or more socially integrated lifestyle. There are, obviously a lot of hurdles to jump, particularly with this new platform of vaccines. They require immense logistical support and temperature maintenance and things that other types of vaccine platforms don't require. So there will be an immense number of challenges in actually deploying them. But, as we've learned, and as was mentioned in the keynote, healthcare has really evolved rapidly because of COVID-19. And I think one of the areas is in healthcare delivery. We've come up with a lot of creative ways to take care of people, and that will include creative ways to vaccinate them.
Great, thank you. You do have, if you look at your chat, you do have a couple questions on the Q&A.
Yeah, so these are both about vaccination. So one participant has asked, do we believe that we may live with it by yearly vaccination like we do with the common flu? That is possible. It's too soon to say. Right now, the two leading vaccine candidates are a multi-dose platform. So it's certainly at least 2 shots to start. But it may be that, we get one as the initial and then a different type of vaccine as the follow-up. And do these vaccines have stability and shelf half-life? So this will ultimately depend on which platform is used, but as I mentioned, the messenger RNA-based drugs require significant cold storage before administration. So it is, that is a challenge.
And I saw where Operation Warp did actually address the cold storage. It has to be something like, I forget, minus incredible.
Minus
What was it exactly, Elizabeth?
minus 90 usually. And they have, you know, elaborate plans for that. The part of the problem with that operation is that a lot of it has been opaque to the public for various reasons that I am not privy to. But I think that will create some downstream challenges because, you know, so much of the other COVID data has been transparent. You know, there are multiple places where you can track cases. You know, local health departments allow you to track cases in your neighborhood. New York City and New York State have maps by zip code, so you can see where disease is happening. And that's, you know, that's sort of unprecedented. Occasionally they will do that for influenza, but there hasn't been anything like that available to the public so easily before. But the data around how they will actually deploy the vaccine has been somewhat shrouded. The CDC has a very basic description of priority listing of who will be vaccinated first, but the practical aspects of that are still not public.
And let me ask you, that's an interesting point. Do you think it will ultimately go to a lottery system of some kind once those that are first in line, or is there any speculation how that will actually then be rolled out?
I doubt it will be lottery. You know, there are groups that they've identified as sort of the first in line, and that's usually essential workers, particularly because vaccination of the healthcare staff has a downstream positive benefit for the entire population because they are able to work and are able to provide care. And then other at-risk groups as well. So there's sort of a hierarchy that CDC has put forward. Some of this is unknown, you know, how the deployment will work. And it's also unknown if some of the other vaccine candidates that don't require the same logistics catch up and also become approved. Not that anything's approved yet, but become, you know, real players in the market, then that may expand the options.
And how do you think this will impact our future population healthcare? Do you think we were totally caught off guard with COVID, in that certainly it's given us a wake-up call that we need to improve what was prior to COVID in terms of our own population health management and systems?
That's a pretty daunting question, but I'll take it in parts. I think, you know, there were definitely certain aspects of the initial and to some degree ongoing response that were not ideal. And I think it did speak to what's been going on, at least I'm speaking from a U.S. perspective. The collaboration or lack thereof, more the contention between state and federal policies has been somewhat problematic in terms of a unified response, and the heterogeneity of how different states adopt policies as their COVID rate increases is also, you know, probably not the most robust way to respond to a pandemic. But on a local level, there has been a lot of information and collaboration. And now I'm speaking from a New York perspective. We've had a very proactive governor and city health department. So both of those have certainly helped mitigate the impact. Although, not without cost, particularly in the beginning of the pandemic. I mean, March and April were very bleak here, and unfortunately, some of our there are still several areas of the U.S. and several other countries that are looking at numbers akin to what we were seeing in March and April. But in terms of what it will do for overall healthcare, as was mentioned in the keynote, the total and utter digital transformation of healthcare, I think, has great opportunity to improve overall health because it can change patients' ability to access their doctor or their healthcare provider, and that I can only see as a benefit. I know my patients love the opportunity to reach me on a video visit, if particularly because my office is in Manhattan and our regional network extends in several directions to New Jersey, Long Island, Connecticut, and it can be sort of daunting to have to come in person. So we're making the best use of that we can, and I think that that's certainly an aspect of this pandemic that's here to stay and will benefit people in the long term. But bringing back to the original topic of our panel, I think the other great outcome of data in the era of COVID-19 is actually figuring out, specifically for cancer patients, that it is okay to come in for care, because that is still a major issue, that they worry about contracting COVID because they come in for healthcare, or people are postponing routine screenings. There are certain types of screenings one cannot do via telehealth, like colonoscopy or mammography. And the data that we have showing us that our healthcare infrastructure is doing okay, and that our PPE works, has helped us over the last several months get back to more normalized operations, and to allow us to continue to care for cancer patients, which I think is an important message that is only possible because of how we've been able to access and analyze the data that we have on COVID-19. See a couple more things in the chat. So this was actually one more question about vaccines. I don't know if there will be a town hall about it to understand the pros and cons. I do know that there are a lot of people advocating for more transparency in the whichever candidates become the first in use. So hopefully the companies will respond with more information when it's available.
So not to occupy the floor here, Doctor, but I do want to hear your thoughts on where this next quote unquote surge is headed. With winter coming, it seems that given that people will be moving indoors versus having had the outdoors to basically give some level of comfort during the warmer weather, do you see that it really is more of a threat with the cold weather coming and people moving indoors? Is that something that really is a real concern that we need to watch?
Yeah, that's a great point to bring up, especially as several areas do enter colder seasons. It's certainly something that we worry about greatly. We also worry about the combo threat of influenza and COVID-19. Somewhat encouraged because data out of the Southern Hemisphere showed that the mitigation strategies that we're using for COVID-19 are dramatically reduced the incidence of influenza during their most recent flu season. So masking and social distancing and hand hygiene. But, it's daunting to think that you could have a patient co-infected with coronavirus as well as influenza. And we're designing platforms to be able to assess that rapidly. So one of the other great stories of data integration and data evolution of COVID-19 is how clinicians have really worked extremely closely with microbiology labs, and our own experience has been a tremendous partnership. We had to scale up COVID testing, as we developed an assay here by our really astute clinical microbiology lab. And then we could only test as many tests as they could make. So we had to really work in partnership with them to plan and evolve from approval-only testing to a really robust clinical decision platform type testing where it's integrated into several processes. So we went from me literally approving the tests and as well as some of my colleagues getting called for each and every individual test in March to having a system where there are automatic triggers. A patient's coming for procedure, they will get this type of testing, or a patient's admitted every 72 hours, they automatically, there's an order for surveillance testing. And we structured those orders so that we could actually feed directly into some data visualization, and we would know if our positive tests were occurring among surveillance testing or if it was only occurring among symptomatic testing. And this helped us really respond to the pandemic and informs all of our downstream efforts. But in terms of what this will mean moving forward, so one way that we'll use this is we also look at our testing by geography. So we can see in areas where the regional data is showing increased rates of COVID-19, we can see if that's paralleled in both our data for patients as well as our data for staff, because we do testing for both populations. And, we have seen that. We've seen that after big events or holidays, there may be an uptick in the positivity rate in certain areas, and usually that parallels the local rates published by the Department of Health. In terms of indoor, certainly close contact transmission has really been demonstrated so far to be the most robust way to transmit COVID. And so it has become, it is certainly a threat as things get colder, but there are still ways to mitigate that. One of them is through the creation of sort of a pod network where you have a limited number of people, potentially your cohabitants in your home, your family members or roommates, whatever it is, and really restricting your outside contacts or outside risky contacts, meaning not having close contact with other people outside of your home. I think the other thing that is happening is that people are evolving to do a lot more things outside, regardless of the weather. And I think that will prove beneficial and potentially essential in making sure we don't face another surge in quite the same way that we had in the spring. I know that that's not necessarily true in all areas of the US in particular, or in all countries, but it is, I think, possible.
So again, another question for you, Doctor. And this is great. I'm really not Dr. Hashmi, but I'm enjoying this, being able to talk with you. You've heard so much, or we've heard so much about the antibodies and the potential of reinfection. So the two questions I have, the first is, do we really know if once you've had COVID that the antibodies, and I know it's been said that they're good for 4 months, 6 months, 2 weeks, 2 days. It's been all over the place. And I'd love to kind of get your thoughts on that, as well as this whole idea then of reinfection. If the antibodies go away, and if you have in fact had COVID, is it really, I've heard where the percentage of reinfection is very low, but then I don't know if we really know. And do you have any insight on those two topics?
Certainly hot topics, definitely things that we are tracking among our patients, as well as, several other institutions are doing the same thing. The reinfection literature is sparse and somewhat contentious. Part of the obstacle to defining reinfection is that you have to have the ability to sequence both the initial specimen and, the subsequent one where you're entertaining the idea of reinfection. And not a lot of places have the ability to do that. Or, patients may have been tested at different locations. And so that connection may not be obvious. Although I do think data repositories will eventually be able to resolve that. For example, we have something called the Health Exchange here, where all the participating hospitals, if the patients consent, you can share medical records among the hospitals in this region. And that's actually been very advantageous to us, because if a patient got tested in March and was positive for COVID, and now they're coming to us in November with a new cancer diagnosis, we will then be able to sort of categorize them if they do end up testing positive for COVID, either as a reinfection or if they've been tested previously and never were positive, that's also informative that they could be a new infection. So the reinfection data, there are only a handful of cases that are, quote, proven. And this is when they have had, as I mentioned, both the initial specimen and the subsequent one, and been able to sequence them. And then there are different guidelines for determining evolution of the virus and whether it's expected evolution within the host or a completely novel infection. The most notable case of this was a traveler who was returning to Hong Kong, had been infected early in the outbreak there, and then as life went somewhat back to normal, had been in Spain, and upon return to Hong Kong was tested and found to be COVID positive as part of their screening protocols. And then both of those isolates were sequenced and determined to be different and different enough to actually be new infection and not just evolution of the virus within that single patient. There are a handful of other cases. CDC makes some comments on these. There was one out of Nevada that they ultimately decided was not a case of reinfection, but instead the other phenomenon that can happen is persistent viral shedding, and that they determined that was more likely the case in that particular patient. But there are sporadic other reports. Your other question was about antibodies, which is a hugely hot topic, both the innate antibody response that we all hope to have, and also antibodies as therapeutics. I'll talk first about your question related to antibody duration and durability. To some degree, this depends on who you are as an immunologic being. There's definitely variable response, particularly among our oncology patients, and that will likely have variable durability and duration of antibody response, and also variable effectiveness. So the initial antibody response to the virus may potentially be one of the main drivers of the severity of your initial infection, and that's a hot area of research at the moment. You know, the antibodies as treatment, that garnered a lot of press after our president had received this therapy, which was a monoclonal antibody therapy designed to combat COVID-19. Most of these are targeting a particular protein on the outside of the virus called the spike protein. And, you know, there's a lot of promise there, but one caution with that is, one, their limited availability, hugely expensive, and it's unclear what their impact would be on the patient's own immune response. So would they then be left vulnerable to reinfection because they had this this external infusion of antibodies and didn't mount their own response? That I don't think we know the answer to yet, but hopefully over the next several months, we'll get a lot more information about it.
And then if I may follow on with another question.
Sure.
We have seen that the rates of infection, new infection here in the certainly in the city and across the country have become record highs. Yet the death toll, if you will, continues to go down. So is it something to be looked at optimistically, in that the reason that the rise in infections is because there is more testing, which we didn't have in the past as much, and that we actually are being able to, if you will, help those that have been infected to prevent their passing, and that's why deaths are going down? You see those two different data points, and since COVID has been so much focused on data, I'd love to hear your thoughts on that.
So first off, one important point about the death rate, and this I think has become more obvious to the public who may not be used to looking at outbreak curves or epidemiologic curves, but has now become much more adept at it thanks to COVID, is that death is always a lagging indicator in an outbreak, in something particularly like this. You know, outbreaks where people die right away burn themselves out a lot faster because you have basically decimated the population that is at risk. COVID, you know, there's a period, the period of transmission and infectivity is longer, and the really severe symptoms actually tend to happen in the second week of illness, after people have been contagious and interacting with others. So the deaths are always going to be after the infection, identification of the infection with testing. I do think, on a positive note, though, that we have learned a lot in the last 11 months about how to care for COVID patients. A lot of that has been through just the sheer amount of case report literature and rapid scaling up of clinical trials with really kind of novel enrollment strategies designed to really respond to a pandemic. One of these in particular is the recovery trial, which was a study looking at a really ubiquitous medication, dexamethasone, which is like a common steroid in every hospital pharmacy. And they had a really open enrollment strategy and really removed a lot of the barriers to enrolling patients, and accumulated about more than 6,000 patients in a short period of time, and then compared them by looking at whether or not administration of stress dose steroids, in this case dexamethasone, compared to usual care, which is supportive for COVID-19, if that had an impact on outcome. And they actually then looked at this in several subsets and demonstrated that for patients who required oxygen supplementation at entry to the study, there was a significant mortality benefit to the administration of steroids. And then they were able to widely publicize this information, and it became a really adopted practice. So the data generation and also dissemination of positive results has really been phenomenally fast during this pandemic. And I think that's really helping to improve patient care and explains to some degree the reduction in deaths as the pandemic progresses. One of those things that the crude measure of death doesn't make apparent to everyone, though, is that patients who recover from COVID face a number of ongoing challenges, whether they're cardiac, pulmonary, or just overall constitutional. And that still, the duration of those symptoms and the hurdles that the patients have to overcome is still an area that's not well publicized. So even if people are not dying at the same rate, there's still a substantial morbidity associated with this disease that that needs to be acknowledged and needs to inform our prevention efforts.
Are there any signs that you have seen that have not yet been really publicly announced that give you hope that we are, quote unquote, at least seeing some light here at the end of the tunnel in terms of managing COVID?
I mean, I don't have a crystal ball or any special hotline, but I do think that there has been a lot of renewed energy and optimism among people for acknowledging the essential role of science in combating this pandemic and sort of a rejuvenation of enthusiasm for science. And that gives me great hope, because it will be the only way a combination of following the science and innate human desire to survive, I think will be what leads us out of this.
Well, I have to tell you, Doctor, between the keynote from Alan and between this session with you, I have great hope. So you've certainly given us, I think, a bright light towards the path going forward. But Ghassan, I see that you are on, and we're rapidly coming to a close here. It's been fascinating, as I say, really stepping in and acting on behalf of Dr. Hashmi. I hope I've done all right, Dr. Elizabeth, but
yeah, much better than than me talking to the void. So
well,
I'm glad to answer questions about this. It's clearly my passion and my joy to do this work.
Well, you're certainly excellent, and you're an asset to Memorial Sloan Kettering for sure, and to the community and everyone else that you serve, which is really notable. But Ghassan, do you have anything that you'd like to basically kind of recap with Doctor, or is as we're coming here, are you Are you?
Oh, thank you so much, Klaus. If anything, really, I would like to first, we didn't have a chance, but again, one more time, congratulations and thanks for Alan on a great presentation this morning. This was really, as you mentioned, like very uplifting to all what we're living at the moment. But also a great thanks for Dr. Robilotti. Elizabeth did an amazing to really bring in the perspective, which is really we're all in bad need for to try to, get over that pandemic that we're living through. But it's nice to see the positive messages as well in regard to the virus. And thanks, Elizabeth, again for giving us that opportunity. Thank you.
Yes, thank you.
And Dr. Robilotti, before we go, I would just like to ask you, and I know this is probably not your wheelhouse, but there's been so much focus now because of the second surge or the resurgence of COVID on PPE. Do you feel that you are and your frontline workers are certainly well equipped to be on the front line and battle this with the equipment and supplies that you have?
Yeah, we've been really fortunate here at MSK. We didn't suffer PPE shortages in the way that some of our colleagues did. But it is actually an area that we closely watch, and it informs a lot of our policy-making decisions about which PPE needs to be worn for which types of procedures. And the way that we achieve this is through a really robust contact tracing effort that's a collaboration between infection control and our employee health service. And any time that someone tests positive, be they a patient or an employee, we look at what PPE was being utilized at the time. And obviously we have, written policies of what's supposed to be done, but we really interrogate what was actually done and then try to find any loopholes or missteps in the use of PPE that could potentially lead to transmission. And I will tell you, since we are talking about optimistic notes, what we have found is that PPE really works, and that using PPE as your infection control practitioners outline really does work, even in situations where there's potential for high risk exposure. We found that PPE has really mitigated that transmission.
Well, on that note too, I'd just like to ask you, how often should we change mask? I've heard all sorts of, facts on that. And I just like to know if I'm changing it frequently enough or if I need to change it more, but is there a rule of thumb on that?
It does sort of depend on what you're doing. We, in a clinical setting, when you could be contaminating that mask with COVID patients, effluvia, of course, we're changing our mask for each patient. But if you are going on I have a stack of masks for my regular life and a stack of masks for my work life. I change the ones in my regular life a lot less frequently, usually influenced by whether I got rained on, it got soiled, or it just starts to smell bad.
Well, that's helpful. So you really believe that the mask is really something that we should all, as a public, be conscientious about, and you really wear it and take it with us.
Yeah, if you can't be distant, you wear your mask. It works. I mean, I can't say it any other way.
Well, you've said so much, and it's been so uplifting and helpful and positive. And I have to tell you, I've enjoyed this session immensely, Doctor. So if you ever need somebody to chat with, please ring me. It's been fascinating.
I'm always happy to chat. And thank you to everyone listening. I appreciated your questions. And to Dr. Abu Alfa for inviting me here, and Rancel, to all of you organizing this. Thank you so much.
Thanks so much, Elizabeth. Thank you.